Hello, good afternoon. Good afternoon, viewers. You are watching us on Raj TV Live. Today, we are going to discuss on oral cancer surgery in COVID-19 pandemic. This program is powered by Betadine, and our scientific partner is Mundi Pharma Bangladesh Limited. Today, we have our international as well as national faculties. Among the international faculties, we have Professor Sanjeev Nair. He is a professor and head Bangalore Institute of Dental Science, lead consultant maxillofacial surgery BM Jain Hospital, and also he is the vice president elect of IAOMS. We also have Dr. Krishna Kumar Thakapan. He is also a professor, head and neck surgery and oncology, Amrita Institute of Medical Science, Kochi, Kerala, India.
Hello.
Hello, sir. We have our national faculty, Professor Motiur Rahman Molla, Professor Oral and Maxillofacial Surgery, Anwar Khan Modern Medical College Hospital, as well as Senior Consultant Maxillofacial Surgery, Evercare Hospital, and he is one of the pioneers of maxillofacial surgeons in Bangladesh, and he was the past president BAMOS. We also have uh, Pro- Professor Belayat Hossein Siddiqui, Chief Surgeon, Head and Neck Surgery Division, Bangabandhu Sheikh Mujib Medical University, Dhaka. He is also the president of Bangladesh Society of Head and Neck Surgeons. Good afternoon, sir. And along with them, we have one of the energetic young surgeons of Bangladesh, Dr. Muhammad Wahidul Islam Prince. He is an assistant professor, oral and maxillofacial surgery, working at Dhaka Medical College and Hospital. So, on behalf of our audience, I would like to welcome you all from Bangladesh to Professor Sanjeev sir, Professor Krishna Kumar Thakapan, and as well as Professor Motiur Rahman Molla sir, Professor Belayat Hossein Siddiqui, and Dr. Prince. Welcome to our today's scientific session. As you know, we all are going last 3 or 4 months. We all are going through a hectic time due to the COVID-19 situation, and most of our daily life are being changed, but disease are not stopping. So cancer patients are coming and they are seeking treatment, and we are always thinking of how to overcome these problems and how to give them a good treatment, making them healthy. So first of all, I'd like to hear from Professor Sanjeev Nair, sir. What changes did you have done in your institute during this pandemic situation, treating the oral cancer patients? Professor Sanjeev Nair, sir.
Thank you. Thank you, first of all, for having me on this show. I'm really uh, honored and I'm really excited about the whole thing. This is the second time I think I am on the Raj TV, and uh, it is a question which is, we keep thinking, and it has already been 3 or 4 months since it has hit us. The pandemic, I think it was somewhere on March 11th that the World Health Organization actually confirmed that we were hit with a new pandemic, and when they declared it a pandemic.
Yes.
And it was too early for us to see what exactly the consequences of the pandemic would be.
Right.
So every day we have been going through, since then, since March, every day we have been going through changes. We have been going through reorganization of our efforts to treat patients. We have been going through policy changes, policy or decision changes. We have had several meetings in the department. We have tried to imbibe what has been going around globally. See, now the most difficult thing was the severity of the infection was different in different parts of the world.
Yes.
Fortunately, because our government had declared a lockdown during the initial phases of the spread of the infection, there was a big breather as far as India was concerned. So we were not overwhelmed with as many cases as we are today. And that gave us an opportunity to really rework on how we would brace ourselves when the actual pandemic hit us, although we never thought it would hit us to this scale.
Yeah,
And so, like I said, again, we are still going through a learning phase. Every day is a new day for us. We keep changing our pattern of work, but we have certain things in place at the moment. And I would love to share that with the audience and people who are
yes,
watching. What
yes,
is there in place for us now? Thank
yeah.
you.
Oh, thank you, sir. Thank you. So, to be exact, are you treating your oral cancer patients regularly, like before pandemic and during this period?
Yeah, so just like I'm going to repeat myself because we had gone through a phase of
Yes.
lockdown when there was absolutely very, very few cases that actually came to the hospital. We had got a big breather in terms of how to tackle the situation.
Yeah.
So it was not really that we had to change the pattern of treatment or the pattern of encountering these kind of patients all of a sudden. We had a very, very gradual learning curve on how to do it. But
Yes.
we never stopped treating our patients. We just took to different ways of handling the situation, like
Okay. That's
prioritizing it, creating a
that.
triage of how to prioritize or who to treat. All those guidelines were built up, and we decided that oral cancer being mucosal cancers of the oral cavity being a priority would receive urgent care from us. So there was no time when we actually had stopped treating such patients. We
Okay.
started then and we continue to do so.
Okay, thank you, sir. Thank you. Now come to Professor Thakapan, sir. As you know, most huge number of patients in our Indian subcontinent, in Bangladesh, India, most of them come at a late stage, needing for reconstruction, sometimes even double flaps. So, not about double flap, but regarding reconstruction, what changes did you do in your protocol in your center during this pandemic period?
Okay, coming, I would probably echo what Dr. Sanjay Nair said. We are all going through the same phases, actually. In the initial phase of lockdown, there was a very low number of cases. But then we always had a policy of treating oral cancers if they come to us. Only thing, we had divided the procedures into three types in our protocol. I'll come directly into our protocol: E1, E2, and E3. Okay, that's what we call. So E1 is like a priority elective procedure, like a thyroidectomy for benign conditions or a benign locally aggressive jaw tumor. So that is E1. Or I mean, E2 is semi-emergency procedures, which can wait for up to 14 days, and that includes all our malignancies of oral cancers, thyroid cancers, parotid cancers. And the third category is E3. That is a real emergency procedures. For example, a patient requiring an acute airway distress, an abscess, bronchoscopic procedure due to a mass. So such things are E3. So all our E3, E2 cases, all our cancer cases, oral cancers probably come under E2. That's like a semi-emergency. So they can wait for 14 days. Up to 14 days. That's what we kept them. And during this 14 days, we asked them to, in the initial phases, we didn't have the policy of testing. Now, at least the testing is available in our institute. And so we do a testing, at least 1 or 2 tests. And we, if the test is negative, we take them for cases after 14 days of quarantine. And we say they should stay in the hospital, not in the inside as an inpatient, but we have a guest house or quarantine setup. So
Oh,
they
okay.
stay there.
That's a good.
And that's how we go about with cancer cases, in short.
Okay, thank you, sir. Regarding Bangladesh scenario, I would like to ask Professor Motir Rahman Mullah, sir. In Bangladesh perspective, what strategy should we adopt to to treat cancer patients during this pandemic period?
Well, it is a real challenging issue since we have the pandemic situation in Bangladesh. As you possibly know that the infection rate in Bangladesh present is very high. Is every day
Yes,
almost like 3,000 new cases, with the death of doctors, senior doctors, I would say, almost like 100 people. I mean, 100 doctors already died. Initially, we didn't have the idea of the tremendous situation of the infection. So initially, I would say this all the hospital management or authority was a little reluctant. So initially, although there is a story came out from abroad that this is a severe infection pandemic, I mean, and things like that, but there was not even a proper mask in those days, in 2 months ago possibly, and that's why many doctors died. You see, and globally, almost like 600,000, I mean, people died already. So it is really a challenge for us. Bangladesh, we don't have the really criteria for the surgery for oral cancer, head and neck cancer. Maybe Professor Bilal would say about the head and neck cancer, but so far about the oral cancer situation, our some of the young doctors are doing this surgery in a certain hospital, but there is no official criteria for like Bangladesh criteria for oral cancer management. But as Professor Krishna Kumar or Sanjeev was telling, that you have to think of the emergency, urgency, and possibly the cold cases. So naturally, if the patient coming to you with an emergency issue like having severe bleeding or severely, creating some respiratory distress, or where you need to go for tracheostomy or quick surgery, things in this condition you have to possibly act immediately. And again, the question is whether the patient is a COVID positive or negative. The big question, and then again, we have to think of the when we do the test. Should we just do the test before going to OT, or isolate the patient at least few days ago, and then possibly force isolation, and then do and test just 48 hours before the surgery, and keep the patient in the hospital. And in my idea, I would say definitely later. My intention is to say that we should possibly have an expert group of surgeons to minimize the time of the surgery, because we cannot really go for a long period of surgery when you have a chance of infecting yourself and the patient. So that is the initial idea that we have here. So we are working like today, BAMOS, they have talked yesterday, and today Dr. Prince and Mustafa has arranged this one. We are happy about it. So possibly in few weeks' time, we will have our own criteria like India they have.
yes, yes.
So with
So,
that, I will go to Mustafa.
so just a small query. If the patient was tested for COVID and if he's negative, he or she is negative, and if we go for surgery, still would we do the same precaution as we would do for a suspected patient, or we
Yeah.
can be a bit free, feel a bit free?
Okay. I mean, from the international studies, it is said that if the patient having suspected, but for example, the the virulency or the aggressiveness is not very that much. You can wait for at least few weeks, then
Yes.
defer the patient for surgery, and maybe you go for radiotherapy or chemotherapy. This is the different opinion of the different centers. So regarding this issue, we didn't have a clear-cut idea in this country, Bangladesh. So possibly there is also not only this option of surgery, but we have to also think of rather curative radiotherapy
Non-surgical
or palliative
treatment.
things. You see, so it
Yes.
would be radiotherapy or chemotherapy as well. Also, so
Okay.
depending
Thank
on
you,
the
sir.
case by case.
Thank you, sir. Thank you, sir. Now I'm coming to Professor Bilayat Hussain Siddiqui, sir. So, as you know, we are maxillofacial surgeons as well as the ENT and head neck surgeons. We are working at a very risky zone. So, what challenges do we have to face, and how can we overcome these challenges to see the patients and as well as to treat the patients?
Yes, thank you, Mr. Moderator.
Thank you.
In Bangladesh, what Professor Mutir Rahman Mullah has said, that actually at the beginning we are rather indecisive what to do, because we have to, actually in my department, we have to work under the umbrella of the university. So university's decision we have to obey, and they actually decided to not to give admission to any patient. That was the primary situation. But it is as somebody has mentioned, that it is every day we are changing our policy. We are, because this is absolutely a new thing to everybody else of us. So we are changing, and now at present, actually, what we are doing, we have decided to start operation, and by this time you'll be happy to hear that we have formulated, Bangladesh Society of Head and Neck Surgeons already have formulated a guideline for our local, in our considering our local perspective, what to do. So you have to triage the patient first thing.
Yes.
As
Yes.
we have got a lot of limitations, we don't have the facilities to quarantine the patient. It is rather difficult, because you know very well that there are very limited facilities for the, even for the doctors also, to keep them in quarantine. So we have to triage the patient. What patient you will see even in the outdoor, that has to be triaged. So we use the telemedicine, and sometimes other inquiries to which patient you have to see in front. And the cancer patient, actually they get the priority. So we have to examine the cancer patient, and again Mr. Thakapon what mentioned, we used to categorize. We used to categorize which one need to be operated immediately and which we can defer, actually. So if I consider the oral cancer, it is sometimes as mucosal cancer, it is aggressive, and that's why it has to be operated. And 14 days to defer it for the 14 days, I think it's not very it's not I'll not support it, because if you defer it for the at least for 3 months or like that, or otherwise you have to process him for operation, because you know in our hospital, if you want to give admission to a patient, it requires more than a month. So we what we have proposed, actually, that we shall operate only on the uh, you have to maintain some precaution for the, there are a lot of scarcity of the equipments in our perspective also. So we shall operate on the patient which are actually uh, have a good prognosis, rather. Because the worst prognosis, the aged patient, the COVID mortality, although it is claimed as 1 point something, 3 or 1.5%, but mortality in the aged patient, more than 70, it may rise up to 25%. So that's a factor, because our head and neck patient, they are mainly aged, middle-aged and aged patient. So that should be considered. So we want to operate with a patient who has got a good outcome. And another thing you have to consider, if we give, if we do the surgery in advanced case, they need adjuvant radiotherapy or chemotherapy. But our colleagues are very reluctant. Even in the international guidelines also, they are reluctant to give radiotherapy in this COVID situation, because it compromises the immunity. So if you cannot give radiotherapy, the surgery will be of no use. So we want to actually operate on the early stage patients and younger patients, so that we can give a result, good result for them, ensure good result for them. But
Okay, sir.
during operation, during procedure, you have to maintain something. The surgeon and the
So during
people.
procedure, we are coming to you regarding the during procedure management of the patients. So I think I got the answer regarding how to deal the patient before the operation. And during operation, we will.
One thing I should mention, as we
Yes,
do not have the quarantine facility, we used
yes,
to do one thing we have fixed up, that you have to test for the COVID 24 within 24 hours of the procedure.
yes.
That's a prerequisite. Within 24 hours of the prior to procedure, you have to test the patient. But if it is, even if it is negative, you have to deal the patient as if it is positive.
Okay, sir.
There
Okay,
is no
okay,
compromise in taking any security measure.
okay, sir. Okay, sir. Thank you,
Because
sir. Thank you, sir.
lot of patients, there are false negative, there are
Yeah,
even
that's right.
fabricated
That's right.
negative patients are also, and there are a lot of asymptomatic patients as well. So
Right.
there is no chance of there is
So
no
we
scope for compromise or
so
reluctance.
we have to be cautious as
Thus, we
like
have to
the
deal
Dr.
each and every
Sanjeev.
patient as
Yes.
if COVID positive.
Yes. So on this note, I'd like to tell to the viewers that this program is organized by Young Maxillofacial Surgeons Forum of Bangladesh. This is a new platform for maxillofacial surgeons, which will work with hand by hand with the other organizations, national organizations of the country. And we chose the name Young just to encourage the younger generations to be in the to be a part in the mainstream, and the person who behind all these efforts were none other than Dr. Muhammad Wahidul Islam Prince. Now I'd like to introduce Dr. Prince and ask him regarding the based on the different international protocols, how would you screen and triage the oral cancer patients?
So good evening, everybody. Thank you, Dr. Mamun, for asking me very good questions. Actually, I want to share some of the data. Actually, worldwide, every year, 2 lakh patients I'm in the every year, and among them, 80,000 are oral cancer patients in every year. And you know that the majority of the patients coming to us, especially in this subcontinent, is 60 to 80% patient among the oral cancer patients are coming to us in advanced stages. So it's a huge burden to our country regarding this. Though it is still a corona COVID-19 pandemic, but we can avoid the cancer patients. So first we decided to make a trials on the basis of trials. So I make a trials on the video conference or teleconferencing to minimize the frequent visit to the patients at this COVID pandemic to the hospitals and the outpatient clinics. So trials is on the basis of the, you know, that the majority of a lot of patients, if I give you data, the sum of the patients, 7 to 13% patients are asymptomatic COVID patients. So that's why we have to treat all the patients as a COVID positive patients, and we make a trials. You know, we categorize the 3 groups of patients for making the trials. One is group A, that is the life-threatening emergencies, you know, so we cannot wait for that. But some of the oral cancer patients that can, if we wait for more than 1 month, it may have a bad impact on the survival of the patients. So that's why this group of patients, especially, we can focus. And third group of patients are those patients, oral cancer patients or head and neck cancer patients. Those we can wait for 6 to 8 weeks, but it doesn't make any bad impact on the survival of the patients. So really we focus on the group B patients, those patients which, if we wait for that for surgery, it can make a bad impact of the survival of the disease because of the biology of the disease. So we make the trials of the patient, our video conferencing and teleconferencing. After sorting this kind of patients, what we did, we give the admission of the patients. Actually, the British Royal College guidelines is for this kind of patients to have to, before surgery, they have to isolated quarantine for 14 days. But it's something like this is majority of the cases is not possible in my country. So what we did, we give the admission of that patients, that group of patients, 48 hours before the date of surgery. And we did we did a COVID test, two COVID tests. One is after the admission, and another is 24 hours before surgery. Because a lot of false negative patients we can got. This is a 30% false negative results. So its number is huge. So that's why we give the two COVID tests before going to surgery, and also we do the CT scan of the chest 24 hours before surgery. So in this way, we try to make a trials, and we choose the patient, younger group of patients, the patients those have more than 65 years of age and have other comorbidities. We just try to defer or postpone that surgery. We choose for that kind of patient is neoadjuvant chemo settings or metronomic therapy. And the patient group which have the equal benefit if we go for surgery or the non-surgical treatment, in that case, we choose the non-surgical treatment of that kind of patients. So in this way, we sorting the patients before going to surgery.
Okay, thank you. Thank you. On that note, on behalf of patients group, on not being a doctor, if I am a patient or I'm a guardian of a patient, if we think, should we consider the patients only on the basis of age or on the basis of comorbidities? Say a 60-year-old patient having no reported comorbidities, another patient, 45-year-old patient having hypertension. Which patient should we choose for surgery?
Actually, this is not only you can choose the patient on the basis of the age. Age is a one factor. If the age is more, then it has a long. If you go for a long duration of surgery, it will have a bad impact. So age is a consideration factor. Stage of the disease also a consideration factor, and also the comorbidities and the biology of the disease. And another thing is very important: the availability of the resources. Because you are decided to go for surgery, but that your human resources, also the operating setup, other health quarter staff is ready for their surgery or not. All these things we have to consider before going to any surgery. Not only the comorbidities or the ages only.
Yeah, that's right. So coming to Professor Sanjeev Nair, sir, do you have any criteria choosing your patients in your center during this pandemic period?
I think it has been more or less discussed on similar lines by Professor Tangapan and Professor Wahid and our other colleagues who are on the panel. We have also got we follow the what is done in the Pittsburgh Medical Center, which is a 3-tier triaging of the patients. So tier 1 are the patients who are completely benign, and patients with surgeries which can be postponed for a considerable period of time. Then there is tier 2, which are usually the biologically low aggressiveness of the disease is taken into consideration there, and tier 3, where our diseases like the melanomas or the squamous cell carcinomas or sarcomas, which need to be operated imminently, those are of course given the priority. Now, the pattern we follow is we try and get initial teleconsultation if possible, but usually these patients are referred to us by other general practitioners or other surgical colleagues. So these surgical colleagues are already told about what to expect when the patients come to us. So we try and finish off most of the investigations in the very first visit as we can, which include examination of the patient, imaging, followed by biopsy, and the blood tests. All these are removed. All these are done in the very first visit of the patient. Following this, we arrange for a virtual tumor board meeting, and during the virtual tumor board meeting, we decide about the treatment plan and whether the patient requires a surgery first or a radiotherapy first. In most situations, as you know, in mucosal cancers of the oral cavity, surgery first is the priority, is the preferable treatment option. So we decide about that, and then we decide about the reconstructive procedures that we can use. And reconstruction, there has always been a dilemma about the ethics involved in deciding about the reconstruction. Now, as a rule, we have been taking up only COVID negative patients. And when I say we have been taking up COVID negative patients, 24 hours prior to the admission, we really test them do the RT-PCR test so that we have a decisive test in hand of the patient being negative and being asymptomatic as well. And if this patient is asymptomatic and negative, we go ahead and plan the surgery. Now, the ethical dilemmas that we face is whether we should compromise on the reconstructive aspect. And we have decided as a rule not to compromise on the reconstructive aspect. So most of our patients do get microvascular flap reconstructions. Apart from such situations as in a patient who is having a second surgery, or a patient who is or a patient who is a very aged patient with, for example, if I take a particular clinical scenario of posterior mandibular lesion, where we would require to remove the entire mandible, half of the mandible. In such situations, we would look at a regional flap rather than a microvascular flap. But otherwise, the thumb rule is do a microvascular flap. We have a two-team technique where one set of surgeons will be harvesting the flap, the other set of surgeons will be doing the ablative work. Prior to all this, of course, we sit down and do a planning of the reconstruction. What I mean by planning of the reconstruction is the creation of 3D lithographic models on which we do a plate bending and everything so that we can reduce the time taken for the actual surgical work that it will involve. And then, of course, the surgical post-operatively. Do you want me to tell you about post-operative now, or you will be coming back to that later on?
I'll come to you later, sir. I'll come to you later.
Thank you.
Okay, thank you, sir. Thank you, sir. So, if I get it right, on behalf of patient, if I think as a patient, if he or she is COVID negative, he or she is getting almost the same treatment as he was supposed to get before the pandemic. Am I right, sir?
Exactly.
Yes.
Exactly.
Thank you.
Yes.
Thank you, sir. Thank you. So now I'm coming to Professor Thakapan, sir. As you are doing surgeries in your center, what safety measures are you taking for the doctors, for the operating surgeons, as well as the whole team?
Right. Very good question. So here again, our protocol divides the personal protective equipment levels into three: the PP level 1, PP level 2, and PP level 3. PP level 1 is for just the disposable gowns, the usual regular protection. PP level 2 will have a little more staged up with the impermeable ground, not the full PP. There again, we'll use the N95 and mask and all those things. And PP level 3 is a full protection with N95, full gear, everything. So in general, if the patient is negative, we go with the middle level of personal protective equipments, meaning that we won't be wearing the whole full gear, because we have, if possible, we get the 2 tests negative. So then we go with the middle level of protective devices. And our, the surgical precautions are also similar to the thing. If it is an emergency case, for example, a patient coming from a hotspot with an airway distress, so we don't have time to do a test or anything. So in that situation, we take him as a positive patient, and then we go with the grade 3 or high level applications. We have a special OR for high-risk patients, or if at all some COVID positive patients. So we take into that special OR with all negative pressure and all donning, doffing, all those facilities are arranged there. So that's the high level of precautions. That happens only very rarely. One situation is if a patient is COVID positive, that we have not got yet for head and neck. The other one will be a high-risk patient that coming from a high-risk zone. but in an acute emergency situation.
Okay, thank you, sir. Thank you. We got it very clear. Now, I would like to come to Professor Motir Rahman Mullah, sir, regarding choosing the team members in a surgical team. How would we choose our team members?
Well, it is always better and said that you have to bring an expert who understand the corona or COVID-19 infection condition and train properly regarding this to protect you full protection or semi-protection, whatever. So you do not bring unnecessary stuff like, say, auxiliary stuff, say cleaner or something around here. So you have to have expert anesthetic group, one or two, and then your surgeon, assistant, and nursing staff. They should be trained properly about, they should understand what is COVID-19 and effect and possible contamination, infection, pre or post or per-operatively, see. So as Professor Krishnan, already Krishna Kumar mentioned about the OT, especially when it is having symptom or positive or something like that, near to positive, we have to be very careful about this. So it means, one, that is important thing, your time should be limited. You cannot go for a long time, as I told earlier. Like sometimes we send our trainee after the prime excision, okay, go do this neck dissection or something like that. But here you have to bring some expert group, and he was telling rightfully that there should be two teams side by side when you need reconstruction. You cannot sit one after excision, you go, same person will go for reconstruction. That's not the case. You have to bring time limitation, and of course they will understand why it is happening, why it is doing that. And then you have to be very precaution about the all the full protection, that is the N95 mask or full PP, or even the some authorities like in from Australia, European Society of Surgical Oncology, they are telling about something like powered air purified respirator is something, you see, is covered here,
Yeah, that's right.
totally
Like
covered.
the astronauts.
Yeah,
Just
yeah,
looks like the
yeah.
astronauts.
Yes, yes. But if it is really somebody who you suspect it is a case of COVID positive, if although
Yes.
as you know that many RT-PCR tests can be negative, but it could be false negative. So depending on the situation and symptom, you have to sometimes very careful about this. So you cannot just, so in short of what I'm trying to say, your team should be smart, should be well oriented about the COVID situation, and act bang bang. Without further delay.
Yes,
And
that's right.
after that, after the surgery, must bring another group who will take to the post-operative care. Anesthetists should be also very, well trained to maintain special groups of COVID patient in post-operative management. Is not the normal post-operative management. Even for the tracheostomy, could be very risky for transmission of the infection. So you have to be very careful about this. Is that
Okay, thank
satisfy your answer?
Yeah, thank you, sir. Thank you, sir. Just one more point, as I have heard yes, Takapan sir, I'm just coming to you. Just one point, as I heard you saying in different webinars regarding the age of the surgeon.
Yeah. Well, that is why I'm in the house sitting here today. So, patient above, our surgeon above 60 years with
Yes, sir.
comorbidities
Yes, sir.
should not be very heroic to go and face this patient disease. So that's why internationally said, or India or even Bangladesh, we say that first of all you survive yourself, then you can think of treating patient.
That's right.
So in the
That's
meantime, what we could do, we think that it is a group practice could be very good idea. Like young surgeon like Prince or Mustafis can act in the field, and we can be a guide through the video
virtually.
conference.
Yes, yes, Yes,
Teleconsult.
virtual connection would be a
Virtual.
very good point. Yes, sir.
You can see
Yes,
the
sir.
patient, see the mouth inside, and discuss with the doctors like Prince or yourself, and
Yes, thank
possibly
you,
give
sir.
your expert opinion to you so that you can act nicely.
Thank you, sir. Thank you, sir, keeping your confidence over us. So,
Yeah.
Thakapan sir, I think you were to add something. Would you please? Sir, would you please? Yes,
Am I unmuted? Yes. Yes. So
yes,
we are taking all extra precautions to before we are operating, and the number of patients with the disease among the in the community is increasing. So I feel we are going to get exposed with the patient, not in the OT. Most probably we will be getting exposed in our clinics or
post-operative settings. Yes.
in the clinics in our regular OPDs. So there, like seeing patients, doing scopies, and all the any minor procedures like taking biopsies. There, I think we have to put in extra effort to wear the protective devices like N95 and all other screening. I mean, outside the hospital screening, so that the patients comes to us only after screening or their temperature checked, or all those things has to be foolproof, so that we will be protected. That's a point which I feel.
Okay, thank you, sir. Thank you. Now, I think operative management, operative precautions, we have got a good point. Regarding this, I'd like to give a floor to Dr. Prince if he would like to add something.
Yes, actually, the protection, personal protective equipment is very important for surgeons and other health workers, those who are in the operation theater. Dr. Krishna Kumar Thakapan rightly said, we just divided the personal protective equipments in three categories. First is the just standard category, standard PP, and then that is only you just wear a mask, surgical N95 mask, normal gown, and without just eye protection, just like this. And the special PP is that it includes the FFP2 respirators, N95 mask. It's a non-porous gown, and you have to wear a face shields. But the surgeons, those who are working in the aerosol generating procedure, like the head and neck surgeons and the maxillofacial surgeons, they are not safe with this kind of PP is not sufficient for their personal protection. That's why another group of PPEs that is called the enhanced PPE. Enhanced PPE, it is in case of mask, that is not the N95 mask. You know that the N95 mask is popular throughout the world in the tuberculosis pandemic, because the N95 mask can protect the virus particle which is up to the 0.3 micron. But
Yes.
COVID virus particle is 0.08 to 0.126 micron, is very less. So the N95 mask is not sufficient to protect the aerosol generating procedure. So that's why they prefer the FFP3 mask or PAPR. What the Dr. Mutir Rahman Mullah rightly said is a powered air purifying respirator. You know, in the powered air purifying respirator, there is a blower within that, and within that there is a HEPA filter, and that HEPA filter is HEPA 13 that can protect completely the virus particles. So for enhanced PPE, you have to choose the PAPR or FFP3 mask, not the N95. N95 is not sufficient to protect you for the aerosol generating procedure. So this is very important. And also you have to limit the surgeons and assistant. I think in this COVID pandemic, the surgery duration of the surgery should be less. So in that case, the surgeon who is efficient more, so he should do surgery. But another thing you have to focus, the British Association of Surgical Oncology, they also said that the most efficient efficient surgeon, we have to reserve him, because if he is COVID infected, so the nation will lose a lot. So that's also important issue. And also we have to focus on the other I think anesthesiologist, we choose the one anesthesiologist who is very efficient and who can give intubation within a short period of time without wasting time. So that's very important. And also the other stuffs, you have to very limit, and they must have the COVID test before entering into the operation theater. So this, and also, the operation theater itself is a vulnerable for the surgeons and those who are working in the operation theater. So there is something, the positive air pressure within the operation theater, and you have to exchange the air 6 times within an hour. That can reduces the virus particles within the operation theater. So this, it makes us a good sense, I think, if you use the PAPR. So now we are also starting in Bangladesh to work with the PAPR, powered air purifying respirator. It's really nice because if you use the goggles, it will makes hazy. So it's absolutely very difficult to do the fine surgery, like the microsurgical reconstruction and other fine surgery in the head and neck regions. Is very difficult because it makes your goggles will be hazy in course of time.
Yeah, you are right. Just I'd like to add one of my experience. One day I was just looking for something in the field. Then my assistant noticed that that's not in the field. That's a small particle on my goggles, which I was seeing through my looks. So it happens. It happens really, and we have to go for something more advanced. So I'd like to hear something from Professor Bilayat Hassan sir, your experience in BSMMU during this pandemic period when you have started treating the patients.
Thank you, Mr. Moderator, for giving me chance at last. So please listen to me. We are talking in a sense that we can formulate everything on ourselves. So one thing you have to realize that this is a global problem. This is a global pandemic, and the people have in many countries have got experience more than us, and they have formulated a lot of guidelines. And you have to follow one of your guideline. Otherwise, you cannot say or you cannot advocate for anything what you like or not. The COVID situation is one of the unique situations that in this situation, you need not to think for patient only. You have to save your staff as well, because your staff are always at risk, and not only at risk, there is a fatality risk. So you have to think of the patient, not only patient, and the surgeon or your staff also. So in regarding patient, what you have told earlier, age is not the only factor. It is never ever. Always when we select a patient, we choose a patient for any sort of therapy. The comorbidities are the very important factors.
Yes,
so you have to consider the comorbidities. Otherwise, only on the basis of age, but age is a very important factor. That's true. That's true. And what I shall say, the OT is one of the main station from where the infection spread. In Wuhan, there are a lot of reports. Only a single procedure have infected all the attendees in the OT. All the attendees, 14 out of 14. So that's a very dangerous station in OT. Because how the the coronavirus spread, we should think the basic things. Because the main thing, what we take about 3 months to realize, that there is aerosolization. It does not spread only by the droplet or only by the contact with the person. It is spread by aerosolization.
Airborne, yes.
Aerosolization is airborne, droplet is also airborne. So it is aerosolization is the specific term. So aerosolization is the microparticles, and it can flow up to 27 feet. Up to 27 feet. So it's a very fantastic thing. We have realized 3 months. We means in global perspective, I am talking. 3 months that aerosolization is a major way of transmission of the disease. So you have to protect your people. So there is no scope of compromising about the PPE. What patient we shall do? In private centers, there are people are doing lot of things. That is not our concern, because they are doing and they are getting infected. That's true. Although we are very sympathized to them, but they should follow the guideline actually. what should be the guideline? Guideline is to triage the patient. What patient you will do and what patient you will not to do. Because in head and neck, and the procedure also, the operating procedure is also important. The people who will be in the OT, that's also important. So I shall say that only the emergency patient, if we do not interfere surgically, which can alter the prognosis, that patient should be interfered. Otherwise not. A terminal stage patient, a stage 4 patient, who will be, if we do not treat, he will survive for 3 years. And if we interfere, then the fate will be same. In that patient, we need not to interfere surgically. Moreover, there are a lot of studies in China and Italy that the patient was COVID negative, but after the cure, he has become positive, and nobody was infected there. How it could be? How it is by aerosolization. Someone was there around who was positive, and that's why aerosolization he got infected. So in the OT, the people who will be in the OT and who will operate on, that's the important thing. There are international guidelines. The people, WHO guideline, the 60 above people above 60 should not go in the front line. This is extra heroic something. That may be a heroic something, but that is not very intelligent action. So you have to, the senior people can take the decision. They can be involved in the making decision who is he need operation or not. But the operation should be done by the middle level specialist, mid-level specialist, the younger specialist, below 50. Or below 55, like that. In my institute, it is below 55. So, and the people also very in the OT attending should be very limited. Very limited, only the essential person, and only 1 or 2 assistant, and 1 or 2 sisters, nurses, and only 1 subordinate staff is enough. And the our anesthetic colleague also must be limited, very limited there, because they are also very susceptible to be infected. So there are the two. So what I am stressing, actually, we are talking a lot of things in many webinars, but we should not try to impose our own thinking. That should be a collective thinking, and that should be under some guideline. So that we can protect all our colleagues in all the centers, because otherwise the people will get infected very quickly or very well. But another thing, when you operate on a patient, you should think you should not transfer him to ICU. Because ICU, there are a lot of crises of ICU in our country. Not only in our country, even it was in the New York also. So you have not give extra pressure to ICU bed. So you should not choose a patient who will require at the end an ICU bed. So that is also considered.
Okay, thank you.
So you have to think everything. It's a total thing. You have to think about the totality. Only not that I'll operate on this patient and not only on that patient. Not if you do that, you'll do mistake. And actually, at the end, we shall see we are losing a lot of surgeons. But this is a reality that they were reluctant. Many of them were reluctant, and that's why that got infected.
Okay, thank you for your points. And now, Professor Motirahman Mullah sir would like to add something. Professor Mullah sir.
I was listening to Professor Belayat. Definitely they got their society possibly had got some criteria for selecting patient for surgery. But similarly, like a dental group also, they did a lot of webinar, and they are on the way to formulate a criteria. But this is the second, I think, regarding the surgical cases, the cancer cases. So that's why we are in the initial stage, I would definitely say. And regarding Prince, he is doing some cases I know in the private hospital. But understanding from the different, criteria of international groups, including India, we are following them, and we're trying to adapt our own strategy in our own the environment, you see. Because if we follow the European standard, we cannot do it. But we have to take the advice or guideline from them and adapt ourselves. And one more thing I would like to add here, the situation in a government hospital or even the BSMU of Dr. Belath, where I used to work there, I know the OT condition generally is okay. But to be frank, for example, the auxiliary staff, for example, the cleaner, the ward boy, they are not trained properly. Should we not go for their training regular first before we go for ourselves to be trained? Because they are the people who are doing the autoclave. They are the people who are bringing all this patient or the other things. So they must be trained properly. And as Prince was telling that they all must be, I mean, they must be tested before they work there, both not only for the surgeon but also for the other staff too, nursing staff and other. And we do not possibly have a good idea about the HEPA filter or carbon filter. That is very important. Even infection can spread from your air condition, which is never been cleaned in BSMU or in government hospital in Bangladesh, who never care about this. So we have to really take care of all these points. And even negative pressure OT, we don't understand this possibly. We have to take care about this. So time has come really to think ourselves and remodel ourselves really to bring all these things. Like some of the doctors in dentistry, they have already brought extraoral high vacuum suction for
Yes,
to
sir.
capture the, I mean, the aerosol
Aerosols.
generating droplets or the air, you see. So
Yes,
that
yes,
is not being there with the other groups. So
yes.
that is why we are sitting together to
Yeah.
have an combined idea so that possibly we help each other and do a good thing for the country.
Yes. Thank you,
So
sir.
I believe that these are the things that I wanted to say in this regard. Prince would say something.
Thank you, sir. Thank you, sir. I think COVID is treating us so many things, and some of them we should have learned earlier.
Yes.
Nowadays, COVID is teaching us. Yes, Dr. Prince, would you like to share something?
Yeah, yeah. I just talk about the aerosolization. Actually, the aerosol, if aerosol is produced, that makes you infected. That's not true all the time. There is a study in Wuhan. They have taken in the COVID positive patients' ear sample from 99 year sample they have collected. Among them, only 26.1% have that kind of viral load that can produce the infection. So only the aerosol produce makes you infected. That is not true all the time. That's the first thing. And another thing is the ICU support. ICU support. Another report in Wuhan, they have do the elective surgery in 34 asymptomatic patients, but among them, 44% needs ICU support. 44% asymptomatic patients. So it's a huge number of things. And you know that there is a large data that have studied among 1,024 patients, and among them 16 to 24% patients are asymptomatic COVID. So always we have to arrange an ICU setup, because most of the cases, in this subcontinent, most of the oral cancer cases coming to us, 60 to 8% in advanced stages. So that's an important consideration. But yes, we can do the new adjuvant settings. We can buy time by giving the new adjuvant settings, new adjuvants, or the metronymic therapy. The metronymic therapy is popular in these COVID situations. You are there in China. They have studied in the metronymic therapy in 23 patients. In that case, they shows that result. The disease is completely cured in a lip stage 4 cancer. Is 30% is stable of that disease by giving the methotrexate and the celecoxib. These two drugs they have given for 6 weeks, and they have find a good results in by giving a metronymic therapy. And the result is that only 30% is stable and 56% has the partial response, and only 13% doesn't give any response. So we have to think all these things. So the Mutiur Rahman Mullah sir, what he added, this is very important. The aerosol where it is produced with a back suck, a sucker which is very close to where the aerosol is produced. That sucker can suck the air 5 to 7 liter per minute, and that air goes through a HEPA filter, which can purify the air and which can arrest the COVID virus particles. And HEPA filter 13 is used in there. And also that air goes through another UV chambers, and then it comes to the operation theaters again. So by this way, we can minimize the aerosol production also.
Okay, thank you. Thank you. Now I'm again coming to our international panel. A quick question to Dr. Sanjeev Nair, sir. How many of your colleagues got positive? Unfortunately, if any, got positive during giving treatment during this pandemic period, after you started from lockdown? Any of them?
Thankfully, none. Thankfully, none. Can you hear me?
That's I hear you. That's great news.
Yeah, thankfully none. But it's an interesting thing. I was listening to all the panelists talking about how important it was to train the accessory surgical personnel in the theater. Now, the one thing that we found in one of our OT setup was every single OT staff except the anesthetist and the surgeon turned out to be positive. So it brings us back to a couple of things. One is aerosolization the only cause for the spread? Or is it the fact that the viral particles, after it is in the air, settle down on surfaces, and bad handling of all the discarded PPEs plus the infected material that is produced at the time of surgery, whether all these can be the cause for the fact that the accessory staff were actually infected, all the accessory staff were actually infected, and not the anesthetist or the surgeon, even though all of them were tested at the same time. So this was a very interesting observation. And like I repeat, none of us surgeons have so far been infected, but we never know. We have to, tomorrow is another day.
Thank you, sir. Thank you. Among us, we have another surgeon who is going to be joined with us, Dr. Abdullah Al Masood. He is one of the energetic and enthusiastic young, as we say, surgeon. He is doing some cases during this pandemic period. Dr. Abdullah Al Masood, welcome to today's webinar.
Thank you, everybody. I express my gratitude to the panelists and very well discussion. I'm hearing everybody's lecture.
Thank you.
Yes.
Would you like to share your experience treating cancer patients during this pandemic period?
Actually, I have to work in two situations. One is in the government hospital and another is private practice. So in my government hospital, I propose my head of the department that we have a long queue for every patient. It's minimum 2 weeks of time. So I give a proposal to my head of the department that when we listed a patient for OT, then we shifted this patient in a cabin, in an isolated cabin, and we send his or her swab for testing. And if the swab come negative, then we go for the next operation. That is our protocol in government hospital. But in private hospital, in which hospital I'm working now, this hospital will not receive any patient without COVID test. So each and every patient I usually do operate after they have done the COVID test and it is negative and symptomless. Then they got admitted in the hospital. Then after 2 or 3 or 4 days observation, then I start the operation with my colleagues with proper protection and everything using 3M respirator. And one thing I have used to practice, I didn't take anything in the hospital premises. That is, in the long operation, need to drink, need to take some food. But during first to last of operation, I didn't take anything in this hospital. So, but there are lots of guidelines. But in Bangladesh, if we want to do the COVID test, it takes 3 days to 10 days. So actually, I attended a AOCMF conference webinar here. They said that they have done 4 hours before operation, they have done the rapid RT-PCR, but it is quite impossible for Bangladesh situation. I think you can do in Sanjeev Nair sir hospital, or Krishna Kumar Thakappan sir working in Amrita. They can do it, but in our situation in Bangladesh, it is quite impossible. So here I used to do the previous COVID test, then when it is negative, then they admit it, then again wait for 3 or 4 days, then see the any chest x-ray and other blood report, then I usually do the operation. Even I have done a couple. So it's actually.
Yeah. Okay. Thank you. Thank you. Any suggestion for the younger generations from your experience?
In my experience, actually, each and every patient should treat as a COVID positive patient and not the patient. If your assistant, your anesthetist, and any other person in the OT theater, you should judge each and everybody is a positive. So you should take the measure like this. I think that is very important. And donning and doffing everything, and your touching and everything, you should give a high precaution.
Thank you. Thank you. So, as I have learned from all of you, that during this period, we are in between the ethics of giving the patient treatment, not to say them no, and safety of the team, safety of the patient. But in between this, it's just walking through the string. You have to be ultra super cautious, and as much as possible precautions you have to take. That's the thing we have got from here. And thank you, Dr. Abdullah Masud, for being connected with us. Thank you. I hope we will hear from you in another episodes for a long period from your experience. Thank you so much.
Thank you.
So we have another young, just youngest surgeon who is doing some surgeries. Where we will hear from him, Dr. Mohiuddin. I think he is online. Raj TV, can you hear me, Dr.
Yes,
Mohiuddin?
yes, I can hear you.
Yes, yes, he is a fresh post-graduated facial surgeon. He is doing some surgeries during this period. Our first question is: didn't you feel afraid doing surgeries during this pandemic period?
Thank you, Dr. Mustafizur Rahman. Basically, the surgeons are afraid because this is a pandemic throughout the world. But we have some liabilities to the patients. So I operate stage 4B carcinoma of oral cavity during these pandemics, which was involved the masseter muscle. And the patient went to several hospitals, but there are so long schedules in these hospitals, and patient came to me. So I have to operate the patient. Almost patient is waited almost 2 months and went to different hospitals in Dhaka.
Please, the people stop talking. Would you just tell them to stop talking? It's just making us noise. Yeah.
Hello.
Yes.
Hello.
Yes.
Yes.
We hear you. So you have operated stage 4 oral cancer patients with reconstruction.
Yes.
So what precautions do you take
First of all, we tested COVID for the patient, and one attendance of the patient.
Yes.
When I found the patient is COVID negative, then we proceed for the surgery, and the hospital patient attendance is minimum, and the hospital staffs were also tested in different centers for COVID. But Bangladesh is a resource constrained country, but continuous COVID testing of the staffs, OT staffs, nurses is not possible. So we have to take some extra precautions, like we use a standard N95 mask during operating time, during operation, and face shield
So
and safety goggles.
your whole team, you used PPE, standard PPE there, right?
Yes, yes.
Okay. How is your team and your patient? Are they doing well? And
Uh,
have you
it's
had
almost
problems?
it's almost 2 weeks, and the patient is still now okay, and flap is still now okay.
And your team members all are okay?
Yes, all are okay.
Okay.
So they,
Okay,
uh,
that's good. Best of luck, Dr. Mohiuddin, for your courage, for standing on the ethical side, not being afraid. But yes, we always should be cautious about ourselves,
yes.
also about our stuff. So thank you being so courageous. Thank you so much,
Thank you,
Dr.
all the
Mohiuddin.
legendary surgeons of oral and maxillofacial surgery. I'm honored to tell something here in this audience. Thank you, sir.
Thank you, Dr. Mohiuddin. Thank you. I think we have given so much emphasis on COVID. Yes, we have to be cautious. We have to be more careful treating patients during this period. But one positive thing that we get from COVID is we are having like Dr. Moti Raman, Professor Moti Raman Mullah sir, Professor Bilayat Hussain Siddiqui sir, Professor Sanjeev Nair sir, Professor Krishna Kumar sir in a same frame, hearing them from my bedroom and having them telecasted to all of the younger surgeons from home and abroad. So this is one of the positive things we are taking from the COVID situation. So apart from COVID situation, regarding the treatment of oral cancer, it needs a lot more discussion. So, should we move to a general discussion about the oral cancer management? What our panel thinks?
We can talk about the follow-up visits, how we can follow up these patients, and also talk about the reconstruction, because Krishna Kumar Thakapan is here.
Yes,
So
yes.
reconstruction is a big challenge
I
because
don't
most
want
of the
to miss
patients are
the
stage 4.
opportunity.
So you talk about the reconstruction, how they do the reconstruction in this COVID situation.
Yes.
Dr. Bela sir can add something. He wants to, before that, he raised his hand to say something about, I don't know.
Yes, sir.
Sir can.
I want to add something that actually power air purified respirator. Can you hear me?
Yes, sir. Yes, sir. Here.
Power air purified respirator is not available here. Although some people are claiming that they have collected it from outside, and it is very costly. And in government setup, it is not available. And negative pressure OT, actually, it is not at all available in our country. It is very specified for some. There are some molecular OT in BSMMU from. It is created recently, built up, and this is not for the COVID patients. These are for the microsurgical patients. So these are not. So we cannot use the negative pressure OT for COVID patients, never. And the power air purified respirator, air purifying respirator, that is PARP, is also not available. So this is our constraints and we should consider it. We have to work with the N95 masks. Even FFP3 is also not available. So and there are a lot of controversy with the N95 mask, Yesterday also there is a report in the TV that in BSMMU, the supplier has supplied the fake N95 masks. So it's a very dangerous situation for us.
Yes, sir. Please take care of yourself and your team. We wish you.
Can I add one thing? Can I add one thing about the
please,
PAPR?
please. very
Sir, with giving you honor, sir, PAPR now it's available. I myself also buy the PAPR. It's not that much of costly item. It's the 40,000, though it's a Chinese item, but that is CDC certified and CE certified, the only one Chinese company. So in Bangladesh, you can buy it from here, 40,000 taka, and it is reusable. So you can use it without changing the filter for 1 year. So if I buy a 1860 mask or 8210 mask, it will cost 1,000 or 1,200. So in 1 year, how much mask you need? You just think. But if you collect the PAPR, I think it is cost effective. And also it gives protection is 99.96% in comparison to the 95%. So that's also, we have to think about this, the PAPR. Now it's 2 or 3 companies are available. Government is spending a lot of money. So PAPR is not that much of costly, I think.
Okay, thank you. Thank you, Dr. Prince. Now I'm coming to the general management of oral cancer. As you all know, the Western people call the oral cancer the cancer of the Indians or the Indian cancer, because we are the Indian subcontinent people, we are cursed with the oral cancer patients. Oral cancer patient number is so high in this subcontinent due to some some habits like betel nut and tobacco. Now I would like to ask Professor Sanjeev Nair, sir, regarding your experience, in your center, regarding the survival of oral cancer patients. Please unmute Sanjeev, sir. Please. Sir, we can't hear you.
Yeah.
Yes, sir.
So if it is disease-specific survival, T1, T2, we have a survival rate of about close to 85 to 90%. And if it is taking a stage 3 or stage 4 disease, it goes down to about 60% in our center. What we concentrate more on is it is quite on par with the global standards of disease-free survival. What we concentrate more on is the quality of life, however, and that is why we are very focused on providing the state-of-the-art reconstructive modalities made available to these patients. That is the focus of our the management of oral cancer. Otherwise, the rest is probably the same as any other center.
Okay, thank you, sir. Thank you, sir, for bringing in the point of reconstruction. Now, I'd like to ask Professor Thakappan, sir, regarding your experience reconstructing oral maxillofacial surgery patients. What are the challenges do you feel or do you have during oral maxillofacial surgery patients reconstruction? Yes, Doctor.
Yes.
Yes.
It was. I would say it was once upon a time a big challenge, but microsurgery has now come everywhere. That's what we are feeling. It has spread throughout India. Many centers are doing it, so we shouldn't say it as a challenge. But considering this reconstruction in oral cavity patients, we can call it like a soft tissue reconstruction and bony reconstruction. Soft tissue reconstruction is for like tongue or buccal mucosa alone, and bony reconstruction is mainly for mandible and occasionally for maxilla. Tongue cases and the options are like free flaps and like loco-regional flaps. There are many good loco-regional flaps also. That's what we should not always think that always we should go with free flaps, but there are very good feasible loco-regional flaps also. For example, like nasolabial flaps, submental flaps in females, and recently we are thinking about an option of a FAM flap. You know, the buccal mucosa with the mucosa along the muscle and pushing it down fully pellicle on the facial artery and taking it inside medial to the mandible for the tongue defects. That's a very cute and nice local flap which can be used for small tongue and especially for floor of the mouth defects. Of course, in free flaps, we have a lot of options. The workhorse flap will be radial forearm and ALT flaps in soft tissue. And if you're thinking of bony reconstruction, especially of the mandible, as Dr. Sanjeev Nair earlier said, we may not actually go for a bony reconstruction if the patient is elderly and edentulous with a trismus. We may not go for a bony reconstruction. Other cases, we go for a bony reconstruction, especially if it is an anterior mandibular defect. And then fibula is the usual choice. That's how I can summarize quickly about the reconstructive options and choices in oral cavity reconstruction.
Okay, thank you, sir. Thank you. Just a quick recall to Dr. Sanjeev Nair, sir. What is your criteria in your center choosing for reconstructive options?
So you are not muted. You are not unmuted.
Sir, you are not unmuted.
So
Yes.
the reconstructive modalities are pretty much similar. We have for the tongue, we are
Sir, you are muted again. Sir, would you please unmute? Yes, sir.
So for the tongue, we use radial forearm, or if in a situation where there is 3/4 glossectomy or a total glossectomy, we use ALT flaps. For floor of the mouth, for buccal mucosa, for posterior mandible, where only soft tissue has to be reconstructed, we use this radial forearm flap. We use the James classification basically for maxillary reconstruction. And most of the times, hard tissue reconstruction, where the body reconstruction is required, fibula is the flap of choice. Very rarely, scapula can be used. Anterior mandible, again, fibula is the fibula, anterior mandible and body of the mandible. Fibula is the bone of choice for reconstruction. The challenge, however, being the rehabilitation of these fibulas because of the height constraints that we have. But we can overcome that by either double barreling the fibula or by using distraction of the fibula vertically. All these can be done to overcome the constraints. DCIS, although is popular for body of the mandible and for maxilla, we rarely use that. So our workhorse is mainly radial forearm, fibula, and scapula. Composite flaps, mostly radial, the fibula along with the skin pad.
Okay, thank you, sir. Thank you, sir. So whatever the treatment protocol we give, we can't ensure the patient full disease-free life. That is, without disease, whatever he was going to live, whatever treatment we give, we can't ensure. So what we should ensure that reduce the number of patients. That is, the less number of patients getting the disease. So on that note, I'd like to ask Professor Motiur Rahman Mullah sir, how can we work on reducing the number of patients, that is the patients getting affected by oral cancer?
Well, that is a big question, you see, because we know the causative factor producing mainly the oral cancer, that is the smokeless tobacco or betel nut or some dental factors, which can be really prevented to many extent by awareness, early screening, or little biopsy in a various way. Like we have a oral cancer society, government registered oral cancer society, where we go every few months to the rural area, do the free health camp, We do initially some awareness program where we talk to the people, the family or the guardian, and then we just say that how it is happening. So we say that you avoid taking betel nut or jorda, gul or koini, or the the tobacco, smokeless tobacco in various form. So that's there, and after that we screen the patient. We examine the oral cavity, and suspected cases we do some simple way of screening program like toluidine blue or something like that. And suspected case we do the biopsy. So in this way, what I'm trying to say, even I sometimes speak to the government, authority, that with a primary health program, if this can be introduced, see, while they are talking to the mother for the child health or mother health, why not they can put another page about the oral health to see how the oral cancer is produced, what is the causes, and what is the prevention. So that is how I think nationally, and of course, I think this is how we will try to control or prevent the increased incidence. Like, the incidence of oral cancer or head neck cancer in this subcontinent is very high compared to the Western countries. It's almost like 25%. In India, they say 30%, or Sri Lanka is such thing. So we don't have much head neck surgeon or maxillofacial surgeon to treat all these patients efficiently. So that's why in a government hospital like Dhaka Dental College or Soy Surgery Hospital, long queue. Like Dr. Masood was telling that all patients are having need to wait for 2-3 weeks before get the OT time. So that is the situation. So where you cannot really go for all cases of like India, maybe they have some good facility and good many staff for doing microvascular surgery after the excision. That is the best way. But still, we have to depend on the local regional flap. Why? Because of the you have to reduce the time, and you do not have that much of expert people to do everything. So that is the reality of our country. So I believe the prevention is very important. That is why Oral Cancer Society or any head neck cancer society can really act on this, formulate something, make a criteria, or talk to the people in the government so that a real system is developed in this country to prevent this, to reduce the number of the, oral cancer patients. Thank you.
Okay, thank you, sir. Thank you, sir. Now, a quick request to Dr. Belayat Hussain Siddiqui, sir. As we know, India has implementing some legislation regarding the use of tobaccos in their country. So, among we head neck surgery society as well as maxillofacial surgery society, BAMOS, can we work together to impose some kind of legislation in our country? Can we work together and bring some legislative changes?
Yes, thank you very much. Yes, we have to do that because we are actually, in fact, we are doing that. A lot of people are doing anti-tobacco campaign in our country
Yeah.
for a long time, and
But
as I
sometimes
had
we need laws.
yes,
Sometimes we
and
need
had
laws.
had an ex-surgical society, as
Yes.
we are not very old actually, but we are also celebrating 27 July every year as a World Head and Neck Cancer Day, and we used to we used to take a lot of program to increase the public awareness about the tobacco because head and neck mucosal cancer, these are all called preventable cancer. So
Yeah.
if you can reduce the use of the etiologies, that is tobacco, alcohol, and betel quid in our perspective particularly, so we can reduce the number of oral cancer definitely, I think.
Okay. Thank you.
And
Thank
that
you.
will be a very good effort. And the policy maker, they should also realize the things.
Yes.
This is we should definitely will work for that, but they should also understand what is going on
But
there.
I think, sir, the duty is on our part. We should go there to make them aware because they are working
Yes,
with some other issues also. So we
it is
should
our
make
duty
our
to
people
knock.
so
It
we
is
can go there.
yes, we shall knock
Yes.
repeatedly, but
Yes.
they
That's
should
right.
also be, well, because they are in 21st century. We cannot think that our politician will be will behave like the 20th or 19th century. That we have to yards together, because if we raise one public and public interest something better in front of them, they should address it properly. It is a
Okay.
bilateral, I think, bilateral.
Okay, thank you, sir. So we have a question from our audience, Dr. Muhammad Mizanur Rahman. He asked, what can we do in case of an advanced tongue cancer? Can we think chemotherapy, radiotherapy in that case? Advanced tongue cancer. So he did not mention the stage. Say we thought it's a stage 4 tongue cancer. What should be the treatment protocol? Should we go for surgery or non-surgical treatments? Dr. Prince.
Yeah, it says stage 4 lesion because he doesn't mention the how many centimeter it is. A stage 4 lesion. Sometimes we can go for surgery if we and we can after resection, compartmental resection of the tongue, we can reconstruct with the ALT flap. But sometimes yes, for downstaging, if it is so advanced, if it is not resectable, in that case, definitely we can go for the new adjuvant setup. And for downstaging, then we can go for surgery.
So I think first thing first, we think whether we should go for curable or palliative, curative or palliative. So Sanjeev Nair, sir.
So yeah, I agree. For tongue, we also have to be specific about the extent of the posterior extent of the tongue. Now, if the posterior extent of a stage 4 tongue disease is beyond the base of the tongue, and if it involves the epiglottis, in such situations, it would be better to combine it with inductive chemotherapy, followed by surgery, and followed by followed by radiotherapy as well, rather than doing surgery itself, because this I would consider mostly inoperable surgical conditions, inoperable conditions for surgery because of the extent of the disease and involving the epiglottis. Now, if the disease is restricted to anterior to that, the base of the tongue is not very extensively involved, and if you can get oncologically safe margin much beyond, say, about a centimeter of margin beyond the epiglottis, then I would be prone to do a surgical total glossectomy with reconstruction using an ALT flap.
Thank you, sir. Thank you. Professor Motirahman Mullah, sir.
Well, I just wanted to add my old experience. When I was trained in Osaka University, so there they used to do some, the brachytherapy, you see, for the, advanced carcinoma involving the base, using interstitial needling therapy. And results were in those times. I'm talking about, say, 1985, 6, those days. So those time, their publication, they have good reports. I don't know whether there will be some comment from Krishna Kumar or Sanjeev Nair or Professor Belait. I would like to request Dr. Belait to say something about the tongue carcinoma involving the base and what is the reconstruction they do after the surgery. If you could, Professor Belait, could say something.
Yes. Yes, in the last part of the last century, this 20th century, that was a very established treatment to do it by brachytherapy, to introduce the iridium needle or gold needle. So these are in practice, and that worked, I think. A lot of people got benefited from those things, but in 21st century, in this time, in our time, this time, it is established that it is better to exercise first. Exercise, do it and address it by surgery, and then followed by radiotherapy. That will give the best result.
And what is the reconstruction?
And the role of brachytherapy is still there. If there is any recurrence, and particularly recurrence in the node, particularly after doing a neck dissection, if there is a recurrence in the neck, so you can, in some centers, they used to treat it by brachytherapy, or even in some inoperable situation also, there is the role of brachytherapy.
So during surgery, what's the means of reconstruction for tongue?
For tongue?
Yes, sir.
It it depends. It depends on many parameters, because what is the extent of, where is the location, what is the extension of the defect, and expertise of the people. All these things will come, and there are a lot of options. We have discussed already many things, and it is not a fixed thing that this flap is always better. Not that. It is. It's a multifactorial thing. So.
Okay, thank you. Thank you. Dr. Prince. Yes, yes, sir.
Professor Sanjeev, I think, or Krishna Kumar would say something, no? About this.
Krishna Kumar, sir, regarding the tongue reconstruction, your experience regarding tongue reconstruction.
Okay, I think I told a little bit about. I think I told a little bit about it. Tongue reconstruction, the options again, we have a loco-regional flaps and the soft tissue, and the free flaps. Loco-regional flaps can be like a nasolabial, submental, or this FAM flap, which I was talking. Free flap will be radial forearm, lateral arm, and if it is a bigger defect, it is like an ALT. Very rarely, rectus abdominis can be used, and we have reported something like gastro-omental free flap. That's like very few we have done cases, like harvesting the stomach greater curvature along with the omentum and using it as a free flap. We have done it in 9 patients with some good results. But generally, radial forearm ALT, as Dr. Sanjay Nair was telling.
So for hemi tongue, you usually use radial forearm and lateral arm.
Correct. For hemi tongue, with the floor of the mouth, if the floor of the mouth is involved, radial forearm is best. If it is just the hemi tongue, lateral arm is a good flap, but the problem is it requires expertise. The pedicle size is very small, so one shouldn't attempt that if he is not very much experienced with that flap. It's a very
vessels are very tiny, and the length is also very short. So, Dr. Prince, would you like to add something?
Yes.
Firstly, before going to reconstruction of the tongue, I want to tell you about something about the excision of the tongue. The neoadjuvant chemotherapy or the iridium pin for brachytherapy, if you think, if it is stage 4 lesion, and if you give for neoadjuvant chemotherapy, it should be downstaging, but you have to excise the previous margin. So yes, that's important thing. That's important thing. One thing I will consider for excision, number was what the Sanjeev Nair sir said. If it is not involve the epiglottis, and if I get a clear 1 centimeter free margin without involving the epiglottis, then I can go for excision first, not neoadjuvant. Because if you go for neoadjuvant, it may reduce the bulk, but you have to excise the previous margin. So it doesn't make any sense to giving this kind of neoadjuvant. So another thing about talk about the reconstruction. Actually, reconstruction, which one you choose, it depends on the size of the defect. If the defect is a very small defect, we can close it primarily without, if it doesn't involve the tip of the tongue, and we can no problem will be happen. And some of the cases, if they without involving the tip of the tongue, half of the near about the half of the tongue we resected, they just give it to raw, nothing else. Also, it gives some good results on this. The Tata people have, I have seen some of the cases in Tata, they did it. And if it is a small lesions, if N0 neck, if a female person, we can submental island flap. I did a lot of cases with the submental island flap. It's a very good result. It's a very good result because you are accessing to the neck at the same time you are taking the flap, and you can transfer into the oral cavity underneath the mandible. It's a very good flap, the submental island flap.
Just one query. In that case, how can you be sure about the nodal involvement in the submental area? What imaging modalities do you follow when you do submental
Actually,
island?
Actually, we can rely on the CT scan and also on the clinical staging. When you at first before going to surgery, we have to depend on the CT scan reporting, and also we can go for the ultrasound also. But CT scan, if you do, you can get an idea. But clinical judgment is the main thing. If the lymph node, because there is a crucial lymph node, is the submandibular lymph node, which is in between the vessels, the submental vessels, and the vessels which goes up to the face. In between this, the submandibular lymph node. If the lymph node is not extracapsular spread, or if it is not adherent to the tissues, you can take it very clearly. And sometimes if it's the N1 neck, also in that case, we can take the submental island flap. A lot of articles regarding this. So submental island flap is a very good choice. And another is the PM flap, fistula, because the PM flap, when it transfers into the oral cavity, there is some leakage of the, if it is not setting very good setup, there is some leakage of the saliva. So in course of time, it's a very, some of my cases, devastating result on the PM flap. But radial forearm free flap is a very good choice flap. It is a very thin, pliable flap. We can choose for that, for the tongue reconstruction. But if the defect is subtotal glossectomy, or in that case, definitely we can choose the ALT flap, because the flap have a very muscular bulk. So we can use that. But in course of time, 50% muscle bulk will be reduced. So it's a very good option for tongue reconstruction.
So on that note, I'd like to add a small point regarding my recent training in South Korea. There, I have seen Professor Zong Ho Lee. He usually does total tongue reconstruction with LD flap, and he does it with neurotization of the thoracodorsal nerve with the hypoglossal nerve, so which gives a very good result. And hopefully, in some webinars, we could connect him to have his experience also.
Can I ask the Krishna Kumar Thakapan, because Amrita is a very good center for reconstruction. They did a lot of case, and they have a very good plastic surgeon, the Subramaniam Iyer. As I know him, he's a very good surgeon, and Dr. Krishna Kumar also very famous surgeon for reconstruction. And do you have any sensate flap for tongue reconstruction in your center?
We have tried in a few patients, but the results were not very good. That's what we feel. So nowadays we don't do it, and we have even tried dynamic flaps, like connecting ALT muscle to hypoglossal nerve. All those things we have tried, but ultimately the results are not far different from what we get without doing all this.
Okay, thank you. But do you think what are the things we have to improve to get our sensate flap working?
Probably, as I mentioned a little earlier, we have tried this gastromental flap. Okay, the gastrosurgeons, they harvest the stomach laparoscopically. The new idea, and then it has the secretions also. Okay, even after radiation, they maintain the secretions. So that's a brilliant idea we have done in few patients. But again, the problem is the reliability of all these new techniques. So we don't want a flap to fail. So when we do new techniques, if the 30% of the flaps or 20% of the flaps fail, that's not a good thing. So that's a problem with all these flaps, newer flaps, including lateral.
Okay, thank you.
Can I add with
another question from our audience?
But I think it is a too long session. So can I leave? Actually, I have got some.
Yeah, we will all leave now. Yeah.
We are having a very.
If you allow me, then.
Yes, sir. Please, if you have, we are just at the near to the end of the session. After a few minutes, we will just wrap up the session.
Okay.
So just one more question. One more question regarding the osteotomy of the bones. What should we use to reduce the aerosolization? Should we use giggly saw or the powered drill or the saw? Professor Motir Rahman Munda, sir.
Well, this is a old tradition that we used to do this giggly saw.
Yes, sir. Sometimes
Again,
old is gold, sir.
if you are, I mean, a smart surgeon, do it quickly, and maybe some extraoral thing, that is the suction, extraoral suction thing, can help reduce. But still, there will be some aerosol generating, you see. But quickly saw would be much lesser, I think, less. That is a yes, please, Sanjeev, Professor Sanjeev.
Yes, please, Sandeep sir.
So I have seen, I mean, not in our center, but I have seen a few pictures of a very intelligent, what do you call it, fabrication of a plastic sleeve that can be used to cover the head and neck region. And the surgeon uses his arms through a portal in the plastic sleeve at the
Yes.
time of the bone cutting, so that there is minimal aerosolization. And this I found were quite an interesting and quite innovative way of reducing the spread of the aerosol. So that could be, kind of adapted. But in our center, see, for example, if we are choosing upper border resection over segmental resection, we would be more prone to do a segmental resection than an upper border resection, because the bone cutting can be minimized in such situations.
Okay, thank you. On this note, I'd like to add a very important point regarding the safety. That is, as you can see, there are some studies that povidone iodine gargling reduces the number of SARS-CoV-2 viruses. This is safe both for patients and as well as for the surgeons also. On this note, Betadine is our partner today, and they are forming povidone iodine in different forms. So thank you, Betadine, for introducing your products for the safety of the surgeons and the patients. Now, I'd like to request Dr. Prince to say something about the effect of povidone iodine. Just in a brief. Just this is the last. Sir.
Okay, just it's a last thing. 1 minute I will take for this. Povidone iodine gargling is a very effective against the COVID virus, because if we gargle with the povidone iodine, it immediately reduces the viral load, and for 3 hours. So it's a very much effective povidone iodine. I frequently, when I see the oral cavity, and I frequently I ask the patient to gargle with the povidone iodine, so immediately it reduces the viral load. So it's a very good, and also CDC recommend the gargling of povidone iodine. So Betadine is a very good option.
Thank you very much. I would be more obliged if I could have heard 2 different hours from Sanjeev sir, from Professor Motiroman Mullah sir, from Professor Thakapan sir, Professor Belayat Hussain sir, and Dr. Prince. But it was really a fruitful session for us, for the younger generations, younger maxillofacial surgeons and surgeons treating oral and maxillofacial surgery cancers. So hopefully we will meet another time with another topics and with more discussions. Now it's just the Thanksgiving. I'd like to give floor to each of our panels to give thanks in a brief. Professor Motiraman Mullah sir first.
Yeah, I would like to thanks and say gratitude to Sanjeev Nair and Krishna Kumar, especially because they are all the way from India, taking their time. They are very busy, I know. In future, we like to work together, and some of our boys are working with you, and thank you for that. And also like to thank, I mean, the what you call the company who is sponsoring. That is the which company is this? That is
Sir, Mundi Pharma.
Mundi Pharma. Yes. So I must say thank, and Professor Belayat. He is a good friend of ours. He is doing good surgery, in especially head neck cancer, and our boys also coming up. So we should collaborate to help our patient to have a best outcome of the patient. Thank you also to Mustafiz for your help.
Thank you, sir.
Prince,
thank you, sir. Professor Belayat, sir.
Thank you, Dr. Prince and Mr. Marata, Dr. Mustafiz, for arranging such a good session for our young doctors. And I also thank the international faculties, Mr. Sanjeev Nayar and Krishna Kumar Thakappan. Probably I met them earlier in somewhere in India,
Yes,
I
yes,
think,
yes.
because both the faces are known to me. So, because I have even last Asia Oceania conference also, I was a faculty there in Hyderabad. I don't know whether you are there or not.
I think, yeah.
So, but then both the faces are, seems to be known to me. Anyway, so you are so kind enough to give us time. Your thinking and your ideas are definitely very much helpful for our doctors. Uh, Thank you very much. And at last, Professor Motiur Rahman Mullah, he's senior to us. And but in the very beginning of his career, when Professor Motiur Rahman Mullah sir, he came back from Japan, I was probably the registrar of ENT, and we worked together also in some cases. For he called me actually for doing tracheostomy in his case, in some cases. So. So we are known since then.
Thank you.
And thank you, everybody. Thank you for giving me a chance here to talk. Okay, thank you.
Professor Krishna Kumar Thakappan, sir.
Yeah, thank you very much, the organizers, Dr. Prince and Dr. Rahman Mamun, and all my other co-panelists and senior professors, Dr. Motur Mullah and Belayat sir. It was a wonderful session. I hope the younger generation and all who are hearing us, they have learned how to manage the difficult situation and especially the oral cancer. And as Dr. Mullah sir was telling, I think we should find some avenues of collaboration between India and Bangladesh, like in maybe in training in microvascular surgeries. We have openings for observerships like for 6 to 8 weeks. So younger surgeons, if they are interested, when the situation improves, they can probably come as observers in our department. So such options can be thought about. Anyway, thank you very much for this wonderful session.
Thank you, sir. Thank you so much. Like I always say that one of the most close friend to maxillofacial surgeons of Bangladesh, Professor Sanjeev Nayar, sir.
Thank you very much. Thank you, Dr. Rahman. My very good friends, Dr. Wahid Prince and Dr. Motul Mullah. I think it was a very interesting session, and I am glad that you have a forum like Young Maxillofacial Surgeons Association, where most of these messages can be spread. Thank you, Dr. Belayat Siddiqui, and it was very good to hear what protocols you follow as part of head and neck management in your center. It was indeed very enlightening, and you have always got my attention and my time. Dr. Prince always picks up the phone and calls me and tells me that I have to be part of it, and it's really wonderful to be with you all, and hope to see you all in person soon rather than have these face-to-face meetings. So thank you once again. Thank you.
Thank you so much. Now I'd like to request Dr. Prince to thank all of them, as well as to say something about the Young Maxillofacial Surgeons Forum.
Yeah, it's a great opportunity for me, and it's a great day for me because in the same platform I'm talking with some of the legendary professors, both from Bangladesh and India. From Bangladesh in India, it's a great opportunity for me. I'm talking the same platform, and I especially am grateful to those Professor Dr. Sanjeev Nayar, Dr. Krishna Kumar Thakappan, Dr. Professor Motiur Rahman Mullah sir, Dr. Belayat Siddiqui sir. They have given their valuable time and they shared their knowledge, and this will enrich the young maxillofacial surgeons in Bangladesh in coming futures, and it will be benefited for that. And I also give thanks to the Mundi Pharma. Especially, I prefer the betadine mouthwash in the COVID pandemic, and Mundi Pharma for sponsoring such a nice webinar, and also gives thanks to the Raj TV, and special thanks for moderation of Dr. Mustafi's such a wonderful moderation of this session. And the Young Maxillofacial Surgeons Forum, I just talk about two things, one or two things. It's a platform for the young, promising maxillofacial surgeons. Though the name is young, but less than 50, everybody can join in this group, and it's a very interactive group. We always share what are the surgeries we're doing.
Young in mind. Those who are young in mind.
young in mind. Actually, that's a very important thing. And we are sharing our surgery, and we are talking about this for a platform. We make this, and we try to some academic programs to enrich ourselves. We try to connect the best, the legendary professors from Bangladesh and also from abroad to enlighten the young surgeons in Bangladesh. That is the main motto of this forum. Yeah. Thank you. Thank you for listeners also.
Yes, I'd like to apologize you all panels to making it a bit large, because I was learning and as well as our audience was learning very well, so I made it a bit longer. So as I always say that we are the younger generations, we are obliged to carry the torch that you have just lit up and given us the chance to follow. So please give praising us, please give teaching us, please give always training us and always inspiring us. Thank you so much for being so kind, so for being with us. Thank you all. Thank you, Professor Motiraman Mullah sir. Thank you, Krishna Kumar Thakapan sir. Thank you, Professor Sanjeev Nair sir and Professor Belayat Hassan Siddiqui sir, as well as thank you, Dr. Prince. And last but not the least, I'd like to thank all of our audience who have enjoyed our session. Thank you all for being with us, and some days in near future we will be with you with another new program. Thank you, Raj TV. Thank you, Mundi Pharma, and thank you, Betadine. Thank you all. So by this note, I'm signing off. Thank you so much. Goodbye. Allah Hafiz.
Bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.